So I'm going to begin with Chapter 60, Care of Patients with Malnutrition, Undernutrition, and Obesity. Whenever we start talking about nutrition, we have to think of the standards and the guidelines. Whenever we are teaching someone about dietary intake, we should let them know that only 300 milligrams per day of dietary cholesterol should be consumed. The patient should choose foods that are rich in protein. They should reduce their intake of calories from fats and added sugars. If the person is over 51 years of age, then they should have a reduced intake of sodium to 1,500 milligrams. Otherwise, they should have a reduced intake of 2,300 milligrams. Now, it's important for us to remember that people are going to consume grains, and when they do, we need to make sure that they're consuming mostly whole grains rather than refried grains that contain fats, added sugars, and sodium. We also have to keep in mind that we have different types of vegetarians that may include eggs or may not include eggs in their diet. Whenever we are thinking of these vegetarians, we have to remember that they might not be getting an adequate amount of calcium, iron, zinc, and vitamins D and B12. Now, when we talk about nutrition status, that is the balance between our requirements and our intakes. And this all factors into our age, gender, disease process, if there's any type of infection going on in the body, and as well as psychological stress. Now, whenever we are taking in a history on these patients, we want to not only assess their food and fluid intake, but we want to assess their psychosocial assessment, okay? Nutrition screenings, they include not only inspection, but we want to measure height and weight. We want to know if the patient has any difficulties chewing or swallowing. And we want to know if there's been any recent changes in this patient's appetite. Now, it's important to remember, to ask the patient if there's been any nausea, indigestion, vomiting, diarrhea, or constipation. We want to know if they have any food allergies, such as lactose intolerance. We want to know if they're being fed enterally or parenterally. We want to know if they've been NPO for 3 days or more. Okay. We want to know if they've suffered any conditions such as fevers, burns, or any type of injury or systemic infection that could increase the need for nutrition requirements. So we want to make sure we're obtaining an accurate height and weight on these patients. Height and weight can be delegated to the CNA or the tech or the unlicensed assistive personnel. Keep in mind that the patient should be measured about the same time every day with minimal clothing and no shoes. Now, when we flip over to page 1236, we see a calculation at the very bottom of the page for BMI. We have weight in pounds over height in inches squared times 703. Now, if a patient has a weight loss of 10% over a 6-month period at any significant time that affects their nutrition, they should be evaluated, okay? So our BMI, our body mass index, that is going to estimate the total fat stores within our body in relationship to weight and height. Now, we do have to keep in mind that we do have those patients that have more lean muscle mass, which will add to their weight, okay? But when we're talking about those that are at least risk for malnutrition, we want to see BMI scores 18.5 to 25, okay? Skin fold measurements, those are more precise body fat indicators, and they can be measured by a nurse or a dietitian. When we talk about protein, energy, malnutrition, we're going to see 3 forms of this. We're either going to see a calorie malnutrition where body fat and protein are wasted, or we're going to see a lack of protein quality and quantity related to calories, or we're going to see a combined protein and energy malnutrition. Now, it's important to remember the malnourished patient, their protein catabolism exceeds protein intake and synthesis, which results in a negative nitrogen balance, weight loss, decreased muscle mass, and weakness. Now, these patients' vital capacity is also reduced because of the respiratory muscles atrophying. Cardiac output is diminished as well because of heart muscle atrophy. Now, patients that have severe malnutrition, we're going to see complications such as muscle wasting, decreased activity intolerance, and intolerance to cold, dry, flaking skin, poor wound healing, and infection. Now, acute PEM, that's experienced when the patient was malnourished or was adequately nourished before hospitalization, but they came into a period of starvation and in a catabolic state from their infection, stress, or injury. Now, chronic PEM, that occurs for those who have end-stage kidney or liver disease or some type of chronic neurologic disease. Anorexia nervosa, that's when starvation is self-induced. It's more of a psychological issue. The patient feels they're fat. The patient doesn't want to become fat. Bulimia nervosa is also a psychological issue, and this happens when the patient binge eats, and then they will purge that food, or they will take laxatives to get rid of that food, or diuretics. Now, it's important that we review the history, okay? We need to review any type of metabolic needs that the patient may have. We need to review any losses. We need to review chronic disease, recent surgery of their GI tract, any drug and alcohol use, okay? A weight loss of 5% or more in 30 days, a weight loss of 10% in 6 months, or a weight loss that is below ideal can indicate malnutrition. Now, on table 60-2 on page 1239, it's going to tell us the symptoms that occur whenever we don't have certain nutrients in our body. So if you look, the very first one is zinc. And if we have a deficiency of zinc, we're going to see alopecia or hair loss, okay? Whenever we're assessing these patients, we also want to assess any type of educational level that they may be having or financial resources, okay? Because this is part of that psychosocial assessment, and we need to make sure that they are comprehending and understanding this nutrition process, as well as we need to make sure they have the financial resources available to buy the nutrients that they need, okay? When we talk about having our patients in the hospital and we're doing calorie counts, it's typically 3 days that we perform a calorie count. So we count every item that they eat, and then it's calculated by the dietitian. Now, serum albumin, thyroxine binding prealbumin, and transferrin, those are all visceral proteins. They measure the visceral proteins. Now, albumin reflects the nutrition status of the patient a few weeks before the testing's been done. Okay, dehydrated patients can have high levels of albumin, and those with fluid excess can have a lower value of albumin. Now, the normal serum albumin level is 3.5 to 5 grams per deciliter, or 35 to 50 grams per liter. Now, when we talk about prealbumin, that provides a more sensitive nutrition deficiency because it has a short half-life of 2 days. Now, the normal range for prealbumin is 15 to 36 milligrams per deciliter. Now, cholesterol, normal levels are typically between 160 and 200 milligrams per deciliter. If the cholesterol level is below 160 milligrams per deciliter, it can be an indicator of malnutrition. Okay. Now, total lymphocyte count, that can be used to assess immune function. malnutrition suppresses the immune system, and it can leave the patient more likely to have an infection. So a total lymphocyte count is typically decreased below 1,500 if we suspect that the patient's malnourished or if the patient is malnourished. I will begin in the next audio starting with interventions on page 1239.